Hello, I'm Dr. Batra. Welcome you all to the today's webinar. So today, first of all, we'll have silence for 1 minute in memory of Mrs. Nilima Guru, who is mother of our CCI LM, Dr. Devi Jyoti Das, and she is survived by 3 children, 2 engineers and 1 daughter. And today we remember her and pray for her family. So we'll observe 1 minute silence for that. Yeah. So Om Shanti, Shanti, Shanti. So, well, I am Dr. Batra, and for moderator for today's webinar. Today we are going to have a webinar on the spectrum of fungal pneumonia and what are the when to suspect fungal pneumonia, the spectrum of various fungal diseases. We have got a esteemed panelist all over from India, and at the outset I would like to thank CCI Central Committee for Dr. N.H. Krishna, Dr. Atri, Dr. Vijay, and the course directors, Dr. Komal Shah, for giving me us and this opportunity to present this webinar on fungal pneumonias. And at the outset, I'll also like to wish happy Navaratri, Ugadi, and Gudi Parva to everybody. So I'll just like to introduce my co-panelist. We have Dr. Swati Behera, who is from Ranchi. He's a pulmonologist and a good friend. And Dr. Divya Kondapi, she's from Hyderabad. She's an ID specialist as well as a critical care specialist. Then we had Dr. Samiksha Medhi, who's also from Assam, a pulmonologist. And Dr. Sushant Sharma from Sharanpur, also pulmonologist. So we have a very good esteemed pulmonologist as well as intensivist as well as an ID specialist with us. So we can clear all our doubts and discuss with them and how to proceed in the today's era and discuss about the various diagnostic methods. So I would like to hand over the mic to Dr. Swati Behera for a talk. She'll be covering the spectrum of aspergillosis, pulmonary aspergillosis, IPA, CPA, as well as ABPA. So over to you, Dr. Swati.
A very good evening to all of you. I am Dr. Swati Behera Sharan. At the outset, I would like to thank Team CCI, Dr. Krishna, Dr. Atri, Dr. Komal for giving me this opportunity to be part of this webinar. I also thank Dr. Supreet Batra, who is the moderator of today's session, for his kind words. I will be talking on pulmonary aspergillosis spectrum, mainly covering ABPA, IPA, and CPA. So let's start with a case which was recently published in China. It talks about a person, a 45 years old man, a vegetable farmer by occupation, presented with complaints of cough, expectoration, fever for 1 month, and shortness of breath for 13 days. History of smoking and alcohol consumption was there for over 20 years. He has no history of allergies or asthma. On admission, patient was tachypneic, tachycardia was there, and the chest showed bilateral breath sounds which were coarse. Numerous rales were present, and scattered bronchi were also heard. The CT chest showed bilateral lung consolidation and cavitation with bilateral hilar and mediastinal lymphedopathy, accompanied by a small amount of right-sided pleural effusion. Now, we will take this case further after having a brief discussion of pulmonary aspergillosis. Now, pulmonary aspergillosis refers to an illness due to allergy, airway, or lung invasion caused by species of Aspergillus, mainly Aspergillus fumigatus. Now, depending on the host susceptibility, the illnesses of Aspergillus can be divided into allergic, saprophytic, or Aspergilloma type, and invasive. Allergic are the severe asthma with fungal sensitization and allergic bronchopulmonary aspergillosis, and the invasive are acute, invasive, subacute invasive, and chronic pulmonary aspergillosis. So in the schematic representation, you can see that that depending on the immune competence and the host immunity, there are various fungal diseases that occur. It can occur shifting in the same patient or in different patients. When there is immune competence and in the presence of chronic lung disease, there is fungal colonization and endemic mycosis. With immune hyperreactivity, there is fungal sensitization resulting in ABPA, ABPM, and with mild and severe immune suppression, there conditions like IPA and CPA are found in these patients. So ABPA is a complex pulmonary disorder caused by immune reactions mounted against fungi, mostly Aspergillus fumigatus. They colonize the airways of patients with chronic lung disease, especially and most commonly asthma or cystic fibrosis. Early detection and treatment is crucial to prevent the progression of bronchiectasis. Screening is essential because ABPA can occur even in mild asthmatics, and there is a high risk of progression to bronchiectasis if ABPA is undetected. Now, this is a pathogenesis where you can see that the Aspergillus conidia, since they are very small in the respirable range, when they are in the range of 2 to 3.5 micrometer, when they are inhaled, the polymorphism of the respiratory epithelial cells and the innate and adaptive immunity results in a skewed type 2 hypersensitivity response, skewed type 2 immune response, which causes release of interleukin 4, 5, and 13, resulting in increased Ig production, eosinophil expansion, and airway hyperresponsiveness, respectively. And this immune response, which is further accelerated, leads to airway inflammation, mucus plugging, and bronchiectasis. So the clinical features of ABPA include, in the history, you have a poorly controlled asthma, wheezing, hemoptysis, productive cough, constitutional symptoms like fever, malaise, weight loss, loss of appetite, which can be confused with the diagnosis of tuberculosis. And reports suggest that the diagnosis of ABP can be delayed as long as 10 years in these patients. There's also expectoration of brownish mucus plugs, and the patient may also be asymptomatic. In the examination, there are features of asthma and bronchiectasis. Clubbing is there, localized consolidation and collapse. And in advanced cases, there is type 1 or type 2 respiratory failure, and also features suggestive of pulmonary hypertension. Now, this is the revised ESHAM ABP working group diagnostic criteria, where along with asthma and cystic fibrosis, they have given COPD and bronchiectasis also as predisposing conditions. The essential criteria include a specific IgE against Aspergillus fumigatus positive more than 0.35 and total Ig more than 500. And other components, any two if positive is ABPA, positive IgG against Aspergillus fumigatus, a blood eosinophil count more than 500, and CT findings consistent of ABPA like bronchiectasis, mucus plugging, and HAM, or fleeting opacities on chest radiograph which are consistent with ABPA. Now, it's important to consider that when specific IgE is unavailable, then a positive skin test, type 1 hypersensitivity reaction, is also acceptable, and a serum IgE of less than 500 can also be taken into consideration if all other criteria are fulfilled. Here, the recommendation mentioned that specific IgG against Aspergillus fumigatus, the value in India is taken as more than equal to 27, and and in the absence of population-specific cutoff, manufacturer recommendations need to be considered. Presence of HAM is pathognomic and diagnostic of ABPA. The recent guidelines have also given the importance to elevated IgE against recombinant Aspergillus F1, F2, and F4, which supports the diagnosis of ABPA and can be used as another component for diagnosing ABPA. Now, in the serological investigations for ABP and the diagnostic cutoffs, the serum total Ig, it's a non-specific marker, but it suggests disease activity, and it's a very good monitoring tool. It is used in follow-up. The total Ig values, they decrease with treatment, and the last recorded value in clinical stability is called the new baseline. If there is a 50% increase in the total Ig from the new baseline, then it is diagnosed as an exacerbation. So the cutoff here is more than equal to 500 international units per ml, as compared to the previous ESHAM guidelines of more than 1000, because a lower cutoff also offers a higher sensitivity, 98% versus a 91% in the previous guidelines. The other investigations are which document Aspergillus sensitization. The specific IgE against Aspergillus fumigatus with a cutoff of 0.35, and it's a preferred screening tool because it has higher sensitivity, 99 to 100%, than a type 1 hypersensitivity reaction that is a skin test with 88 to 94% sensitivity, but it has a limited utility in follow-up. Specific IgG, Aspergillus fumigatus, cutoff has been mentioned as 27 with a sensitivity and specificity of 89 and 100% as compared to the previous used serum Aspergillus precipitans, which had a sensitivity of only 27%. The blood eosinophil cutoff has been taken as 500 cells per microliter and never used alone because it's a non-specific test. These are certain radiographs. On the left of left X-ray, you can see central bronchiectasis, and on the right side, you can see this opacity, which looks like a fingering glove opacity. These are various types of bronchiectasis seen in ABPA with signet ring appearance and advanced central bronchiectasis, which you can see almost extending to the periphery. HAM, if present, is very specific and pathognomic. So the revised ESHAM guidelines have also given clinical classification and treatment response. They have staged ABPA, and as compared to the previous guidelines, they have not labeled it anymore, and they have included newly diagnosed and observation patients in acute ABPA itself. Response is when there is symptomatic improvement by at least 50% in both in radiological improvement as well as decline in serum total IgE, at least 20% after 8 weeks of treatment. Remission if there is good clinical response and there are no symptoms for more than 6 months of glucocorticoids, and also there is no rise in serum total IgE for more than 50% from the new baseline. Treatment dependent are the ones within 3 months of stopping glucocorticoids, they have 2 or more exacerbations, and advanced are the ones with extensive bronchiectasis and features of cor pulmonale or type 2 respiratory failure. So this is the diagnostic algorithm. If the screening tool is positive, then total IgE more than 500, blood eosinophil count of more than 500, elevated IgG, and a CT scan when done. If there is no bronchiectasis, then it is ABPA-S with bronchiectasis, ABPA-B with mucus plugs, ABPA-MP with HAM, ABPA-HAM, and with pleuropulmonary fibrosis is ABPA-CPA. Now, when the screening tool is negative, then repeated isolation of non-Aspergillus species is done. Sensitization to detect sensitization to the implicated fungus. If total IgE is more than 500 or 2 of blood eosinophil count, or a fungus IgG or CT findings are positive, then a diagnosis of ABP-M is made. So the principle of treatment is anti-inflammatory treatment in the form of glucocorticoids or biologic agents which target the type 2 immune response, or antifungal agents which decrease the fungal colonization in the airways. And there were various studies which compared high dose oral glucocorticoids with low dose glucocorticoids, and it was found that there is no change in the number of exacerbation in these patients. So the recent ESHAM guidelines recommended a low to moderate dose of oral glucocorticoids in these patients. They started with 0.5 milligram per kg per day for 2 weeks, followed by 0.5 milligram per kg per day for alternate days for 8 weeks, and then taper by 5 milligrams every 2 weeks to discontinue over 3 to 5 months of treatment, or 0.5, 0.25 and 0.125 milligram per kg per day for 4 weeks each, and then taper by 5 milligrams every 2 weeks till discontinuation. So the main purpose was to give the treatment for only 4 months, around 4 months. Or antifungals can be given like triazoles, which have similar effects as glucocorticoids, but they have a slow trajectory to improvement and also a better safety profile than glucocorticoids in the doses of 400 milligrams per day in 2 divided doses for 4 months. So the stepwise management of ABPA patients is newly diagnosed ABPA patients should be given oral glucocorticoids or itraconazole for 4 months. They should be followed up with spirometry, serum total IgE, and chest radiographs after 8 to 12 weeks. If there is response and it is a sustained response, then they go into remission. And if there is an increase in symptoms as defined earlier, then there is exacerbation. If it is a first exacerbation, then the same treatment is given, oral glucocorticoids or itraconazole for 4 months. And if there are frequent exacerbations, then a combined therapy is given for 4 months. In treatment-dependent ABPA patients, oral azoles, type 2 anti-type 2 biological agents, nebulized amphotericin, and low-dose glucocorticoids are considered. Coming to the next entity, that is the invasive pulmonary aspergillosis, which is a fatal infection caused by angioinvasive fungus aspergillus. The acute manifests within 1 month and subacute manifests between 1 to 3 months. Diagnosis is challenging because the nature of the symptoms and the lack of highly sensitive diagnostic tests. So the risk factors here of IPA are, the traditional ones are neutropenia more than 10 days, hematopoietic stem cell transplant, solid organ transplant, systemic glucocorticoids more than 3 weeks. And the emerging ones that we see in today's setup in ICUs is critical illness, ICU stay more than 7 days, chronic liver disease, COPD, post-H1N1, COVID-19, diabetes and HIV, to name a few. So the diagnosis of IPA is graded according to a scale of probability, possible, probable, or proven, which we will see in the next slide. CT thorax is a cornerstone. I have given a few CT pictures where you can see the opacities. There are bilateral consolidation with cavitation, and also You can see in the next picture, there is a nodule with surrounding ground glass opacity called a halo sign, which is also a characteristic in invasive aspergillosis. So the mycology tests include demonstration of the fungus as in histopathological examination of biopsy or surgical specimens, culture, or the fungal biomarkers like galactomannan, both in serum and bile, and 1,3-beta-D-glucan, which is only in serum, and the positivity of Aspergillus DNA real-time PCR. So these are a few pictures of invasive aspergillosis, a few CT pictures where you can see the rapidly progressive invasive aspergillosis in COVID-19 patient, in COPD patient, and this is a CT in an immunocompetent patient where you can see that there is ground glass opacity throughout the lung. So the diagnostic classification of invasive pulmonary aspergillosis is done according to the European Organization for Research and Treatment of Cancer and Mycology Study Group. According to immunocompromised patients, these are the criteria. There are certain host criteria, clinical criteria, and mycological criteria. Possible IPAs are the ones with one host and one clinical criteria positive. Probable are the ones with one host, one clinical, and one mycological criteria, and proven are the ones which have been proven on histopathology with or without PCR positive. And it should be noted here that this does not apply to immunocompetent patients that we see in ICU settings. So this is a meta-analysis which shows that the serum galactomannan and PCR, when taken together, the specificity is 98%, whereas the specificity is as high as 100% with bile galactomannan, and the specificity in bile is only 94% when taken together, galactomannan as well as PCR. Coming to the last entity, that is the chronic pulmonary aspergillosis, it is seen in immunocompetent or mildly immunocompromised patients with an underlying lung disease like COPD, post-tubercular disease, and NTM, treated lung cancers, where you have a air-filled cavity or a bulla present. There are distinct patterns of CPA with overlapping clinical presentations. They can be aspergilloma, chronic cavitary or fibrosing variety, and microinvasive forms of pulmonary aspergillosis. CT image is the key to diagnosis, with aspergilloma being a hallmark. The other features on CT can be expansion or wall thickening of a pre-existing cavity, parenchymal destruction of fibrosis, which develops around a pre-existing cavity, or a pleural thickening or effusion, and an enlargement or pseudoaneurysm of a bronchial artery. So the microbiological documentation is through a culture, from sputum, or invasive through a bronchoscopy with bile. Aspergillus PCR is very sensitive, but it does not distinguish between colonization and infection. And when CPA patient is on antifungal therapy, PCR helps in detection of azole resistance. A positive PCR is a good predictor of azole resistance. Galactomannan in bile has a sensitivity of 75 to 85% and a specificity of 75 to 80%. In serum, it has poor sensitivity, so it is not recommended. The anti-aspergillus immunoglobulin IgG or precipitance is a good positive predictor value for diagnosis of CPA, and it is recommended for diagnosis as well as monitoring response to therapy. So the antifungals that are used in both the entities, there are 3 classes of antifungals currently licensed: the polyenes, that is the amphotericin B formulations, triazoles, voriconazole, posaconazole, isobuconazole, and itraconazole, and the echinocandins like casmicafungin also, and anidulafungin. The novel antifungal drugs with potent anti-aspergillus activity like the olorifim and fosmanogepix are generally reserved for patients with azole resistance IPA. So here you can see that triazoles are the treatment of choice, the first choice in IPA management, and polyenes are the second choice in IPA. Triazoles are also used in the treatment of chronic pulmonary aspergillosis, but echinocandins are not used as monotherapy, and they should always be considered in severe or refractory cases. So the therapeutic approach is, when suspected, diagnosis should not be delayed for more than 24 hours. Triazole in proven and probable IPA, liposomal amphotericin B in possible IPA. Baseline liver and kidney functions need to be done, and possible drug-drug interactions need to be kept in mind due to the inhibition of cytochrome P450 enzyme. Combination therapy is only reserved for severe and refractory IPA, and treatment should be given for at least 6 to 12 weeks, depending on the recovery of immunosuppression and the evolution of CT findings. PET CT can be considered to monitor the response to therapy, but in immunocompetent ICU patients, shorter 4 to 6 weeks treatment can be given after discharge from ICU. The management of CPA is complex. A multidisciplinary approach needs to be followed. Surgery should be considered on an individual basis, mainly to prevent hemoptysis, to limit hemoptysis, and also to prevent fibrosis formation. Because of the chronicity of the problem, CPA patients generally have a long-term antifungal therapy because the response is very slow and almost partial in most cases. And after stopping antifungals also, they may lead to recurrence and exacerbation. So again, coming back to the case, a vegetable farmer by occupation. The laboratory investigations that were done at the initial visit shows increased serum total Ig, serum specific IgE was positive, IgG against Aspergillus fumigatus was also positive, and the serum galactomannan was also high. The histopathology in Ball specimen showed hyphae and spores. So a fungal etiology was consistent. That's how IPA diagnosis was made. And also the patient fulfilled 2 major as well as 2 minor criteria for ABPA. So this was consistent with the diagnosis of ABPA. So the diagnosis in this patient was made of a IPA with an ABPA overlap. He started with IPA and later on ABPA was also found out. This patient was treated with a combination antifungal. He was given voriconazole and amphotericin B and regularly followed up till after discharge also. And re-examination showed a downward trend. Of course, it did not return to normal. And you can see this as you can see on admission, this was a CT picture which with extensive consolidation cavitation and serial CTs. You can see at the end of 6 months, the patient was almost with very minimal symptoms or no symptoms at all. And at the end of 1 year, you can see that this CT, there is a lot of radiological improvement. And that's all I want to say in my talk. Thank you to all of you. Now I hand over to Dr. Supreet on the next presentation.
Thank you, Dr. Swati, for a wonderful talk. Now, my talk is on a diagnostic approach to fungal pneumonias. So, out of 5 million fungus, there are only hardly 300 fungus which are pathogenic to humans. They have been subdivided into 3 groups, like yeast-like fungus, that is Cryptococcus, Pneumocystis, and Candida. Then we have dimorphic fungi, which are also called endemic fungi, because they are endemic to certain regions in the world, like Africa, South America, North America. And why they are called dimorphic? Because they are spores at 37 degrees Celsius and they germinate at 25 degrees Celsius. Then we have molds called haline mold, that is septate fungus, Aspergillus and Scedosporium. And then we have mucorales mold, that is aseptate, rhizopus, and mucor. So, as we all know, fungal pneumonia, when we know fungal pneumonia are common in immunocompromised people, but they can also happen in immunocompetent host also. But all people who, though fungus is present everywhere, it is ubiquitous in the environment. It is present in our skin as well as in our respiratory tract. But at that time, when we do suspect fungal pneumonia, there has to be some background history or some factors which will lead us to that this might be a fungal pneumonia. So when a patient presents with clinical syndrome of pneumonia, we have to suspect. When to suspect means there are certain factors like host factors, epidemiological factors, certain radiographic patterns, and when the pneumonia is not resolving. In that cases, we have to think of fungal pneumonia. So what are the factors which can predict or which can tell us that this might be a fungal pneumonia in an immunocompetent host? So there are certain host factors. We all know fungal pneumonia are common in immunocompromised host, but it can also happen in immunocompetent host, and these are dimorphic fungal infections most commonly. Then fungus can also colonize the airways of patients with chronic lung disease and can also cause disease in patients with chronic organ dysfunction, like patients with emphysema, bronchiectasis, sarcoidosis, prior history of TB, cavities, patient with cirrhosis and uncontrolled diabetes and diabetic ketoacidosis. Then there are some epidemiological factors also, like severe influenza or SARS-CoV-2 are a risk factor for pulmonary aspergillosis. Near drowning is a risk factor for Scedosporium pneumonia. IV drug abuse can cause candidemia and with secondary hematogenous dissemination to lungs. Smoking cannabis and tobacco leaves can cause Aspergillus and Cryptococcus infection. Exposure to bird and bat droppings and visiting caves can cause infection with Histoplasmosis and Cryptococcuses. And traveling to endemic regions in South America or Africa can cause infection with dimorphic fungi. Primary Candida pneumonia is very rare in immunocompromised and competent host. Growth of Candida from respiratory sample should always be represent colonization rather than infection. So there are some suggestive radiological patterns which can also guide us to that this might be a fungal pneumonia, like a halo sign, that is a nodule surrounded by a ground glass seen in mostly in the upper lobes. Then we have a reverse halo sign, that is ground glassing surrounded by consolidation, that is seen in usually mucor infections. Then we can have bilateral perihilar diffuse infiltrates and pneumatoceles, which may suggest this is pneumatoceles, and this is a barrier which may suggest that this may be a pneumocystis infection. Then we may have cavitating nodules in the peripheries of the lung subpleural, which may suggest septic emboli from Candida endocarditis. So fungal pneumonia, typically they affect the upper lobes. Nodule presentation is the pulmonary nodule are the most common presentation. And pulmonary nodules along with concomitant sinusitis cavity increase the likelihood of mucormycosis. And if you see mediastinal lymphadenopathy, think of granulomatous fungal infection like histoplasmosis and coccidiomycosis. Non-resolving pneumonia without an alternative infectious or non-infectious cause should prompt us to for investigating for a fungal infection. Acute fungal pneumonia is not uncommon. It can be caused by mucormycosis, TCP in a pneumocystis in immunocompromised host, and ARDS secondary to histoplasmosis, acute blastomycosis, and coccidiomycosis. Now, once we have made we have set up seen the risk factors, that there are some risk factors. So after seeing the risk factors, if the pretest probability of fungal pneumonia is very moderate to high, then we should do diagnostic testing. And the diagnostic testing should be liberal in immunocompromised patients. But in immunocompetent patients, we should first use non-invasive test. And if they are not negative, then we can go for tissue sampling. Non-invasive test, conventional testing. That is conventional test, I mean, is microscopic examination, culture, though they are low serology, and molecular testing. So first non-invasive test, conventional testing should be done. If they are negative, then we can think of alternative diagnosis. They can be negative because they are low sensitivity. So we can think of invasive testing. And if they are still negative, then we can go for advanced testing like next generation sequencing or broad fungal PCRs. So after taking all the results into account, the clinical, we should differentiate whether this is an infection or colonization to establish a level of certainty of disease, whether it is proven, probable, or a possible fungal infection. So coming to the conventional testing, that is microscopy. Microscopy can be performed on sputum, oral washes, bowel, and lung biopsy specimens. They give a preliminary diagnosis of infecting fungus. If we see a Coccidus spirules on the microscopy, that gives a definitive diagnosis. Medium-sized, broad-based budding yeast with thin double refractile walls suggest blastomycosis. And if you see broad hyphae that are aseptate and branch at 90-degree angle and twist in ribbon formation suggest mucor. There are certain specialized stains like mucicarmine stain for detecting cryptococcal capsule, and there are fluorescent stains for detection of pneumocystis. Negative staining, negative microscopy generally does not rule out fungal infection because they have low sensitivity. Coming to the culture is the gold standard for diagnosis. In the right clinical scenario, it indicates infection. It means if there are factors, host factors, environmental factors are there, and there is a suspect, and there is a radiology, and if we grow fungus, though in the right clinical scenario, it is infection. But sometimes we see in culture, we do a test for bronchoscopy, and we found that there is maybe a positive culture. So a positive culture, if the clinical syndrome is not compatible, it suggests colonization or specimen contamination. Then cultures can also provide antimicrobial sensitivity information and antifungal resistance. And various fungus grows at different rates. Some grow very fast, like Candida, Cryptococcus and mucor in 1 to 3 days. Aspergillus take 3 to 7 days, and the dimorphic fungi, they are slow-growing fungus and take 2 to 3 weeks. Pneumocystis does not grow on culture. Again, fungal cultures have low sensitivity. Negative cultures does not rule out possibility of fungal pneumonia. Coming to antigen testing, this is a non-invasive test. They have a short turnaround time. It can be done on blood, urine, and bowel specimens. The sensitivity of antigen is highest in the bowel, followed by urine and serum. They are used for rapid diagnosis of cryptococcus. Cryptococcal antigen sensitivity is 80 to 100%. For aspergillosis, we have galactomannan antigen, and its sensitivity ranges from 20 to 90%. Then we have pneumocystis and dimorphic fungal infection, which can be diagnosed by beta-3-1-glucan testing. False positive galactomannan can be seen in case of when you use electrolyte solutions, consumption of certain foods. And there was a thought previously that beta-lactam antibiotic like amoxiclav, piperacin, tazobactam is no longer a cause for false positive galactomannan. Beta-1,3-glucan assay, it is a pan-fungal antigen that can be used for fungal diagnosis and is positive in fungal infections except Cryptococcus, mucor, and blastomycosis. Serum 1,3 beta-D-glucan in pneumocystis pneumonia has sensitivity of positive predictive value 90% and negative predictive value 95%. So it is a very good diagnostic test in PCP. Can be performed on bile, sputum, and nasopharyngeal secretion and induced sputum also. Beta-D-glucan can be false positive in blood in the patients who are given blood products, albumin, use of gauge, the cardiac has a cross infection, and IV immunoglobulins. Coming to antibody testing. Antibody testing is useful in case of dimorphic fungi, coccidiomycosis, and also can differentiate between acute and chronic pulmonary histoplasmosis. Coming to molecular assays. Molecular assays, we have got broad range molecular assays, that is pan-fungal PCRs. Then we have pathogen-specific PCRs. Then we have molecular tests for antifungal resistance. Then we have whole genome sequencing or next generation sequencing, NGS. And then these are the fungal metagenomics. The purpose of this talk is to discuss about the latest diagnostics which are available in the market, and we daily see so many assays are coming, biofire assays which are used in diagnosis of bacterial and fungal infections. So knowledge of this molecular test is very important because they have got a very good sensitivity, but at the same time they grow some abnormal pathogens which are not of significance. So we go through the literature why this molecular tests are very important, very sensitive, and what are the pitfalls. Coming to the broad-based PCRs, they can be performed on blood, fresh tissue, and also formalin-fixed tissues. They have high sensitivity and specificity compared to conventional cultures, and the diagnostic utility of PCR was superior in the tissue as compared to liquid or fluid media, and it was particularly low in the CSF. As an alternative, PCR-based assays along with HRM analysis we call as biofire, they detect species identification, they detect mutations with associated antifungal resistance. Until date, there are only two biofire which have been FDA approved, that is for meningitis and encephalitis panel and BCID panel. Again, the limitation of this is they detect novel or unexpected pathogens which may be not related to the obvious clinical syndrome, and there is a lack of standardization of these methods. Coming to pathogen-specific molecular assays, that is Aspergillus PCR. They are the Aspergillus PCR is the most standardized PCR till date, and it has been included in the EORTC or MSG ERS guidelines. This Aspergillus PCR is used for both screening of early infection as well as diagnosis of invasive aspergillosis. It can be performed on both whole blood and respiratory specimen, that is the BAL, and it has got a faster turnaround time. In blood specimens, sample 3 ml of more than 3 ml of blood is required, or more than 0.5 ml of serum should be there, and it can be used for screening early infection and also diagnosis of invasive pulmonary aspergillosis. So this is a very good sensitivity Aspergillus PCR. Even it's a non-invasive test, and we can do by doing the blood samples. It has got high sensitivity in transplant patients, neutropenic patients, and patients admitted with intensive care with post-influenza and COVID-19. As we know, influenza and COVID-19 are risk factors for pulmonary aspergillosis. Antifungal therapy, if antifungal medicine has started, they reduce the specificity but does not affect the sensitivity of the Aspergillus PCR. So it's a very good test for diagnosing invasive pulmonary aspergillosis. At the same time, there's a misnomer. Aspergillus PCR testing on BAL sample should not be used for screening of invasive pulmonary aspergillosis, because we know Aspergillus is colonizing our airways. So it should not be used for screening. Aspergillus PCR testing on BAL can be used for diagnosis of invasive pulmonary aspergillosis, and Aspergillus PCR testing on respiratory samples other than BAL should not be used. That is nasopharyngeal aspirates, ET aspirates, or the sputum. Antifungal prophylaxis reduces the sensitivity of PCR in BAL fluid. So as compared to BAL, Aspergillus PCR test in the blood is more sensitive for invasive pulmonary aspergillosis. Coming to PCR for pneumocystis, we know pneumocystis can be diagnosed by conventional methods like microscopic examination, that is fluorescent staining, and also detection of beta-313 glucan, which has got sensitivity of 90%. But there are molecular assays also for the detection of pneumocystis, and quantitative real-time PCRs are preferred. They can be done on induced sputum, BAL fluid, and also nasopharyngeal aspirate and serum, but sensitivity is higher in induced sputum and BAL fluid. Coming to PCR for Cryptococcus PCR, we know Cryptococcus can be diagnosed by conventional method like culture and detection of cryptococcal antigen in blood, which has got sensitivity of 80 to 100%. So because the cryptococcal antigen test sensitivity is very high and it is easily accessible, the DNA PCR for Cryptococcus is not widely developed. Coming to Candida, we know Candida, you used to send blood cultures for candidemia, but now there are very good PCRs available, which as compared to blood culture have reduced faster turnaround time. They are superior in diagnosis, and they can help directed therapy. Whole blood is required over serum sample, sensitivity is 95%. T2 Candida is the only FDA-approved assay and has been included in the guidelines. It can detect 5 major pathogens under the umbrella of Candida, like Candida albicans, tropicalis, glabrata, Cruci, and parasilosis. The limitation of this test is prior antifungal therapy may reduce the sensitivity of this test. It got a high cost and it can enable it to distinguish between certain Candida species like albicans and tropicalis, and inability to detect other Candida species. But it is a very good test for detecting candidiasis as compared to blood culture. Coming for mucor, we know conventional real-time mucor PCR are available, and they can be done. Testing can be done on serum, ball, and fresh and formalin-fixed tissues. Real-time PCR are preferred because they have faster turnaround time, reduce contamination, and potential to quantify fungal burden. COT-H gene is an emerging diagnostic target and is universally present in all the mucor, but this has been tested only in the mice urine, and the detection was more than 70%, 90%. So further validation is required in human cohorts. For resistance, antifungal resistant detection, whole genome sequencing should be used because that gives a genome-wide view of gene mutations, and they can also detect new mutations that otherwise may be missed with targeted DNA sequencing. And when to do PCR for antifungal resistance, when you see a clinical failure on appropriate antifungal therapy, or there's a relapse or developing new infection after prolonged antifungals, there's a high local resistance in the community, or there is limited UCAST and CLSI compliant phenotypic testing, or when you see borderline susceptibility or resistance resulting from phenotypic testing. So by identifying resistance, that can guide us on clinical decisions. Now coming to whole genome sequencing and next generation sequencing, they can be performed on cultures and can be performed on direct patient samples. They are very accurate in identifying the causative fungal pathogen. They can also detect novel or emerging pathogens like Candida auris, which is pan-azole resistance was detected by NGS, this next generation sequencing only. This NGS can also detect antifungal drug resistance, and they can also detect intra-host evolution of pathogen, that is in vivo development of resistance. And they can also help to differentiate or find out a fungal outbreak situation in a hospital or ICU. What are the limitations? Comparative studies are very limited. High quality reference genomes are very limited, and computing power, storage space, and expertise and cost is very high for this NGS or a whole genome sequencing. Coming to the catch-all principle, that is the principle for this one, fungal metagenomics. This is a principle that is capacity to detect all the pathogen, bacteria, virus, fungi, and parasites simultaneously in a clinical sample. So this can detect, identify pathogens, antimicrobial resistance, virulence, and can also be used for microbiome analysis. So this is fungal MNGS that we call as fungal metagenomics. Now coming to newer antifungals, there are newer antifungals in the market which are like coming up in the market. One of them is risafungin and ibrixafungrab, that they inhibit beta-1,3-D glucan. Then the other fungus is nicomycin Z, which inhibits the chitin synthase. Then we have opalconazole and isovaconazole. They inhibit ergosterol synthesis. Opalconazole is the only nebulized antifungal. Then we have phosphonogypix, which inhibits GPI and code proteins. And then we have olorofim, which inhibits the dehydrogenase enzyme, which inhibits the nucleic acid synthesis. So these are the newer antifungals, and the trials are going on these newer antifungals. Let's see the literature for this. Risafungin is the most studied, and it acts against Candida and Aspergillus, but has no action on mucor and Cryptococcus. Ibrixafungrab also has no action on Cryptococcus and mucor, and active against Aspergillus Candida. Then we have fosmanogepix, which is active against all Candida, Aspergillus, Cryptococcus, and mucor. Then we have oloroform, which is active against only Aspergillus. So these are the newer antifungal which are phase 3 and 4 trials are going on for them. And risafungin and ibrixafungrab, they inhibit the cell wall synthesis, that is by inhibiting the beta-1,3 glucan, and they are in the trials for invasive candidiasis. Very good drug, risafungin. The half-life is 130 hours, and it is usually given once in a week. Then we have phosphonogypix, which is oral and intravenous. It is also in the phase 3 trial for candidiasis. Opalconazole is a only nebulized antifungal, which is used in phase 3 trial for invasive pulmonary aspergillosis. And then olorofim, which is an oral intravenous form, which is also in the phase 3 trials for invasive pulmonary aspergillosis. Now coming to this is my last slide for aspergillosis spectrum. This is the relationship of fungal disease with the host immunity. So if the host immunity is good, that is immunocompetent host, the fungal they colonize because they are ubiquitous in the environment. So they colonize our airways. They are present on our skin. So they do not cause any infection. They colonize, and an immunocompetent host, endemic mycosis, endemic fungi can cause because of the large inhalation of spores. But if our immunity becomes overactive, that can lead to fungal sensitization and lead to development of ABPA or ABPM. But if our immunity decreases, mild or severe immune suppression, then that can lead to chronic pulmonary aspergillosis, invasive pulmonary aspergillosis, endemic mycosis. So these are the spectrum of aspergillosis disease based on the immunity of the host. So if there's overreactivity, that leads to sensitization. If there is immunosuppression, that leads to invasive pulmonary aspergillosis. And for diagnosis, we have fungal culture. We have seen immune-based tests. We have seen the PCRs, the digital PCRs, multiplex, and NGS and WGS, that is whole genome sequencing. And we have got the newer antifungals coming up, risafungin, Bexafungerab, fosmanogepix, all these are coming up for the treatment of this, for the treatment of aspergillosis. And we have got immunomodulators for ABPA. And if they are resistant, like in case of resistant to treatment, then in that case, surgical resection or lobectomy in medical resistant cases can be done. Thank you. Yeah, so now, after having two talks, now we are going to have a panel discussion with our esteemed panelists, and we'll be asking some questions, but specifically discussing on the common fungal infections we see in our practice, like based on Aspergillus, Mucor, and Pneumocystis, and what are the role of newer newer test molecular assays, their role, and newer antifungals. And already we have so many webinars previously on ABPA, so we'll not be discussing ABPA much, and we'll be starting directly with Aspergillus spectrum and in our patients. So my first question is to Dr. Swati Behera, that how common you see fungal infection in your clinical practice, and what kind of population are those? Dr. Swati, you are on mute.
Yeah. Thank you, Dr. Supreet. Fungal infections are actually very highly prevalent in immunocompromised hosts, but when we see it in immunocompetent patients, it is generally seen in patients who are in our respiratory patients. It's generally COPD, emphysema, bronchiectasis. All the patients who have post-tubercular patients who already have aspergilloma or NTM, treated lung cancer, and in our ICU setups, post-influenza, COVID-19 are the patients, and those who are diabetics or dialysis patients and cirrhosis patients, post-transplant, of course. So these are the general group of patients that we see fungal infections in these patients.
Basically, we see infection both in immunosuppressed and immunocompromised and immunocompetent patients. But our lung patient, those who have previous diseases like cavity or a previous COPD, asthma, they have the airway the colonization is there. So those patients with chronic respiratory disease also have colonization, and they also mostly the fungal infection are seen in them in our population, whatever the population we cater. So my next question is to Dr. Divya. Dr. Sushant, what are the different forms of chronic pulmonary aspergillosis, and what is the role of radiology in diagnosis? Dr. Sushant, you're on mute. You are on mute, Dr. Sushant. Dr. Sushant, you are not audible. Yeah. Yeah. So I'll go for the next question. My next question is to Dr. Divya. how you diagnose chronic pulmonary aspergillosis, and what is the role of microscopy culture and the role of antigen testing in diagnosis?
Hi, Dr. Batra.
Yeah.
So basically, the thing about, say, chronic pulmonary aspergillosis is a lot of it truly, if you look at the diagnosis, a lot of it is history taking, radiological, and clinical pretest probability. Because if I actually look at individual tests, none of them are very reliable for different caveats, and I'll go through each one of them. So, for example, we'll start off with, say, the spectrum of chronic pulmonary aspergillosis. You can have aspergilloma, you can have aspergillus nodules, you could have chronic cavitary pulmonary aspergillosis, you could have chronic fibrosing pulmonary aspergillosis, and you can also have multiple nodules. Like, this is a spectrum of diseases. So the first test we'll discuss is IgG antibodies, Aspergillus fumigatus specific IgG antibodies. So when you look at, say, aspergilloma, I would say probably and you can tell me what your experience has been as well. But literature says that the serum IgG antibodies for fumigatus can be positive in up to 90% of people who have aspergillomas. If they have high burden of aspergilloma disease and it's negative, then you wonder if these patients are mounting antibodies against another species of aspergillus that's prevalent in that environment. Now, the same level of antibody positivity may not occur if it's just an aspergillus nodule. If it's a single nodule or very few nodules, you may not get the same level of antibody positivity in them. When we get to the spectrum of chronic cavitary pulmonary aspergillosis or chronic fibrosing pulmonary aspergillosis, the IgG, assuming that the prevalence of Aspergillus fumigatus in that area is very high, the antibody positivity in these diseases is also very high. Now, of course, this doesn't confirm the disease. It is just a supportive finding. Now, the second thing is in terms of, say, cultures, whether it's microscopy, cultures, etc., their presence, their growth doesn't automatically equate to disease. They have to meet clinical pretest probability. They have to meet radiological probability. So that is essentially the issue, because a lot of the patients that have pulmonary aspergillosis, they also have underlying structural lung disease. They also have sometimes some of these older patients who are smokers, or they have overall, I would say poor lung structure, overall poor health. Apart from having poor structural lung disease, they may have had structural lung damage from TB in the past. They may have structural lung damage that have led to mycobacterial infections, and all of these compound the structural lung damage that allow aspergillus to colonize the airways. So even cultures or even PCR testing in these patients is not very good. Now, you get a little more confidence when it's from the lower airways. Like, for example, if I take DL cultures, these aspergillus cultures can be positive in 20 to 80% in those with actual disease. You get a little more confidence when you see these cultures. But again, you have to take the whole context into picture. If I look at, say, PCR testing, PCR testing can be, it depends on the study that you do. But PCR testing sensitivity can be, depending on the study, anywhere from low 70s to high 80s or mid 50s to low 90s. I've seen multiple studies with different results, even PCR testing, for the same reasons. Number one, it depends on whether they're colonized or not. It depends on if they've received treatment or not, etc. In terms of galactomannan testing, Aspergillus galactomannan testing, serum testing is not very reliable. If you use a cutoff of, say, 0.5, if I'm not mistaken, your sensitivity is only between mid 40s to mid 60s. So it's not a reliable test. If you look at galactomannan sensitivity on the BAL, actually, let's talk about negative predictive value. If you look at negative predictive value of galactomannan on the BAL, that is quite high. That is anywhere between high 70s to low 90s. That is a bit more of a useful test. But serum testing itself is not very useful. So these are the important things. Molecular testing, I'll get to it at a different stage, because I think we have that as a separate question in our panelist discussion. I won't discuss that right now.
Yeah, so well said, Dr. Divya. We have to take a clinical context into picture. It's not that we can generalize directly on sputum or culture for the diagnosis of chronic pulmonary aspergillosis. We have to take the antigen testing and in the clinical picture into account for the diagnosis. And for that, patient should also have the background setup and also the symptoms. So well said. So we have to take all the things, and not one single test can help in diagnosis or clinching a diagnosed CPA.
Yes.
Now I come back to Dr. Sushant. I already this has been covered by Dr. Divya, the clinical spectrum. Can you just re-elaborate, Dr. Sushant? What are the different types of CPA and what is the role of radiology in diagnosis?
Yes, sir. Am I audible now, sir?
Yeah, you are very well audible.
Okay, sir. Sir, for as far as radiology is concerned, aspergillus nodules appear as single or multiple nodules of usually size less than 3 centimeters on a CT film, and with or without cavitation. And on they may mimic uh, if they have speculated margins, they can mimic a carcinoma, or if internal cavitation is present, they may mimic rheumatoid nodules, and sometimes they look like a tuberculoma. And on histopathology, there is no tissue invasion, and necrosis may or may not be present. Now coming to the second one, simple aspergilloma or a single aspergilloma. It appears as a single cavity containing a fungal ball. So here it would give appearance of a air crescent sign sometimes, and the fungal matting on the surface interior surface of the cavity, when the fungal matting it breaks off and falls into the cavity and coalesces, and it forms a fungal ball. And as far as progression is concerned, there is no radiological progression. So hence it is called simple aspergilloma. Then there is the entity called chronic cavitary pulmonary aspergillosis, which was earlier called as the complex aspergilloma, and it can have a single or a multiple uh, plural or pulmonary cavities containing may or may not contain fungal ball inside them. And as far as it can have perilesional infiltrates, and some fibrosis may be there. And very typical is pleural thickening and associated extrapleural dense fat, and sometimes alveolar consolidation may also be seen. And these cavities are usually expanding, and there may also be new cavities emerging. So when these new cavities and small cavities, they coalesce over time, and they give appearance to the next stage, which is the chronic fibrosing pulmonary aspergillosis, which is more or less the terminal stage of this spectrum, and there is a complete major loss of lung function, and it may be associated with pleural thickening, and sometimes the whole of the hemithorax may be involved. And at least two lobes should be involved to call it CFPA. Otherwise, if it is limited to one lobe, then we will call it chronic CCPA, chronic cavitary pulmonary aspergillosis. On the other end of the spectrum, there is another entity called subacute invasive aspergillosis, or it was earlier called as the chronic necrotizing pulmonary aspergillosis, or the semi-invasive form, and usually seen in mild immunocompromised hosts. And there is a very rapid progression. Initially, the X-ray or CT will be normal, and within a matter of few months, less than 3 months, there would be a new consolidations emerging, and giving rise to new cavity formations. And treatment will be on the lines of invasive aspergillosis. So this is the complete spectrum of CPA, where there are five entities. Nodules may be there, aspergilloma, or CCPA, CFPA, and subacute invasive aspergillosis.
Yes. So very well put up, Dr. Sushant. But also radiology helps in diagnosis or also exclusion of CPA, because if we see cavity size is increasing or there's an appearance of new cavities, that suggests that the disease is active, and we have to work on the work for the cause. Maybe a chronic pulmonary aspergillosis is around. It's not just a static cavity. Maybe in the increase in the size or appearance of new cavities. So my next question is to Dr. Medhi. How do you treat and follow up this patient with chronic pulmonary aspergillosis? You are on mute. Please unmute yourself, Dr. Medhi.
Hello, everyone. Am I audible now?
Yeah, you are very well audible.
Chronic pulmonary aspergillosis, first we have to treat them with azoles because they are the first line of therapy. And initially the drug of choice is either an itraconazole or a voriconazole. And suppose the patient is not responding properly to voriconazole or itraconazole, then we can switch to other newer drugs like posaconazole or isovaconazole as a salvage therapy. So if we go first as a first line of itraconazole or voriconazole, we will have to at least give the drugs for a period of 3 to 6 months, and mostly 6 months, because the response to treatment is usually slow. And we have to look for serial, either a biomarker test if a galactomannan test is available, and if we know the value of the galactomannan test, then we can see the serial levels, trending level, whether it is decreasing or not, as a response to see whether the patient is responding to therapy or not. And suppose the patient is responding adequately, we go for a 6 months therapy. And suppose we find that he is not responding, then we go for the newer drugs. And other drug, like suppose we find the patient is resistant to azoles, then we can go for a liposomal amphotericin B, which we can give in a dose of 3 to 5 mg per kg body weight. And for voriconazole, we have to start with a dose of 6 mg per kg body weight IV BD for initial 1 to 2 days, and then go for 4 mg per kg body weight. And when we switch to oral, initially we can start with IV and then we can step down to oral. When we are giving oral therapy, then we can start with 400 mg BD followed by 200 mg BD over a course of 6 months.
So the thing is, azoles are the drug of choice if not responding, liposomal amphotericin B. But one thing I want to add is you have to reduce the immunosuppression, because one of the causes for this is immune suppression. You have to reduce, and sometimes they say that the dose of steroids has to be reduced, or the antifungal has to be continued till the immunosuppression is there. Till you are giving the immunosuppressant. So that is one thing. And in case of hemoptysis, also in case of CPA, we can use intra-bronchoscopically, we can instill antifungals, because this aspergilloma do not have any blood supply. So you can't give any, and embolization cannot be done. So in that case, antifungal intra-bronchoscopically can be used to help in tackling the hemoptysis.
Yeah, and suppose if the patient is not responding medically, then there is a option of surgical treatment. We can surgically remove the aspergilloma, or if there is a single cavity, we can also remove it. If suppose the patient is complaining of repeated hemoptysis, etc.
Yeah, that is the definitive treatment. If surgery is possible, it is the first treatment of choice. And bronchial artery embolization is just to pass the time so that to prevent a massive hemoptysis. Yeah, but treatment is all obviously surgical for the aspergilloma. Okay, so coming to the next thing, we have gone through the CPA, that is chronic pulmonary aspergillosis. Now we come to invasive pulmonary aspergillosis. And my first question is, Dr. Medhi, you only. What are the risk factors for invasive pulmonary aspergillosis?
Yeah, so we have already discussed in the previous slides the risk factors. So there are the classical risk factors and the emerging risk factors. And classical risk factor is obviously the immunocompromised patient who has a prolonged neutropenia, who have neutrophil deficiency. Then there are patients of hematological malignancy, hematopoietic stem cell transplant patients who are chronically immunosuppressed, or patients receiving chemotherapy, even solid organ transplant recipients. HIV patients. These are the classical patients, or also patients who are on long-term corticosteroid therapy. Then again, in this, we are having emerging risk factors in ICU, like critically ill patients. They may be immunocompetent, but still they are at a risk of having invasive pulmonary aspergillosis, especially in the post-COVID era, because we are seeing a lot of COVID-19 associated aspergillosis, kappa. And also we find invasive aspergillosis in patients who had severe H1N1 infection and the ICU stay was prolonged, or initially they had a lot of steroids, and after that, having a hospital acquired fungal infection. And also in patients who have uncontrolled diabetes, or a CKD, CLD patient, patients on steroids, not long term, even a course of 2 to 3 weeks of steroid can cause 15 to 20 mg dose of prednisolone, can cause immunosuppression, and ultimately lead to invasive pulmonary aspergillosis. So these are the factors that I think we should look into, and they are the most high-risk patients of invasive pulmonary aspergillosis.
Yeah, well said. So that there's a term which has been there, that is IAPA, that is post-influenza associated pulmonary aspergillosis, and kappa, that is COVID associated pulmonary aspergillosis. This is a well-known entity that pulmonary aspergillosis can be seen in patients with influenza, because normally we see a lot of patients influenza, ARDS, pneumonia in our hospital, but we do not suspect aspergillosis in those patients. We keep on treating with antibacterial, antivirals, but we have to consider sometimes aspergillosis can be a reason for not resolving of the pneumonia. Patient keep on ventilator, or one of the reasons for ARDS also. So very well said, doctor. And then now I come to Dr. Swati Batra. You had a very good talk. So I would like to discuss how we diagnose invasive pulmonary aspergillosis in a given patient. What are the criteria?
So invasive pulmonary aspergillosis is actually a disease of the severely immunocompromised patients. So the classification or the diagnosis criteria was given by the European Organization for Research and Treatment of Cancer and Mycosis Study Group. They had actually given 4 criteria: the host criteria, clinical criteria, mycological criteria, and a proof of invasion. If there is a proof of invasion with a positive histopath with or without PCR, then it is a proven IPA. And when the host criteria, like the criteria for immunosuppression, that is hematological cancer, solid organ tumor, transplant patients, and treatment with immunomodulating agents, all these are the host criteria. The clinical criteria are suggestive mainly from the radiological features, like of a nodule, mass, or with or without a halo sign, or an air crescent sign. All these are radiological criteria. So if one host and one clinical criteria is positive, then it is a possible IPA. And if we add mycological criteria to both of these, that is one host, one clinical, and one mycological in the form of a positive direct examination or a culture, either from sputum or bowel, or for positive galactomannan, with or without PCR from serum or bowel. This is also a criteria which fulfills the requirement for a probable IPA. So basically there are three categorization: possible, probable, and proven. So it is difficult because of the array of the clinical symptoms and the tests that are not so specific. So histopathology always remains the mainstay of the diagnosis. If we are able to prove it, then it is a proven IPA.
So that's very well said. So as the name suggests, invasive pulmonary aspergillosis, there has to be an invasion, angioinvasion. So that can be demonstrated only by histopathology. So that is what then only becomes proven. But most of the cases, I think what we are treating is in the category of probable, not even possible, because we see we have a patients who have clinical history, host factors, and we do a bronchoscopy, get a bowel sample, and galactomannan is positive, radiology is positive. So most of the patients are in a category of probable we are treating, and I know it's very difficult to get a biopsy because there are chances of bleeding also is there. And if it is something which is peripheral, we can take a CT guided biopsy also. But angioinvasion is must to diagnose it as a to make it as a proven invasive pulmonary aspergillosis. Okay, so now my next question, Dr. Sushant, what is the role of antigen testing and molecular assay in diagnosis of invasive pulmonary aspergillosis? Please unmute yourself.
Yes, sir. So I would start with the microscopy appearance, how it looks on the microscopy. The fungus looks like a septate hyphae with dichotomous branching at acute angles. And culture also is useful as it helps in the selection of um, uh, choice of antifungals. And in this context, on a culture specimen, we can also use mass spectroscopy or genome sequencing to confirm our species identification. As far as antibody testing is concerned, it is low sensitivity over here. And among the antigen based tests, I think galactomannan has to be the most useful. It is a part of the polysaccharide cell wall of Aspergillus. It has high sensitivity and specificity in bile samples as compared to blood samples. And galactomannan sensitivity is even higher than cultures, and um not to be used for sputum or tissue biopsy samples. And we can also have some see some cross reactivity with other species like Fusarium alternaria or histoplasma. So it may give sometimes false positive results. And another antigen test is here 1,3 beta D glucan, which is a cell wall part of the cell wall of most of the fungi. So it will be seen positive in most of the other fungal infections also, like Candida or Pneumocystis, but it is negative in Mucorales and Cryptococcus. So now coming to the molecular part, molecular testing. This Aspergillus PCR testing has been also included in the diagnostic workup now, and serum and plasma samples are highly sensitive, more sensitive as compared to BAL or CSF samples. Sometimes the sensitivity in blood samples have been reported as high as 90%, and if we combine with galactomannan, then sensitivity it if further increases up to even beyond 96%. So then again, Aspergillus PCR is the most polished one among these fungal PCR testings, and it also gives a very high specificity. Sometimes some of the studies have even reported specificity of even up to 100%. But still, some false positivity may be seen with some other species like Rhizopus or Fusarium or Penicillium. And apart from that, some point of care testing like lateral flow assays which detect galactomannans and other extracellular glycoproteins. So they are also coming up now.
Yeah, so just to add on this, Aspergillus PCR is the latest test or molecular assay which has been included in the guidelines, and it is comes in the category of probable IA diagnosis. And as I have discussed in my slides, it can be used on the blood. So blood has more sensitivity than the bile fluid. So that's what, and it can be used not only for screening of infection, and IA probable diagnosis is included in the criteria for IA probable diagnosis. So this is the latest advancement in molecular assays for Aspergillus PCR. So coming to Dr. Divya, how do we treat invasive pulmonary aspergillosis?
So, Dr. Batra, it depends on multiple factors. One is what is the host factor, like how immunosuppressed they are, what medications are they on, I mean, including immunosuppressants and also medications that can interact with any proposed azoles that you want to start, where the disease process is, do the drugs get to that location well, does this person need surgery, etc. So the most common, the first thing you would like to do is usually the drug of choice is voriconazole. The starting dose is 6 mg per kg twice a day for the first day. That's your loading dose. And then you go to 4 mg per kg twice a day. And then you get a level at around 5 to 7 days and you aim for a level between 1 to 5.5 mcg per ml. Ideally, you would want to go higher if it's CNS disease that's included along with pulmonary invasive pulmonary aspergillosis. Then you'd want to go between 2 and 6. But this is the usual trough goal you'd go for. If it's below that, you would obviously have to increase your dosage and then recheck your level in a few days. And if it's above that, where you have symptoms of toxicity, including hallucinations, delirium, skin changes, etc., then you would have to be careful and either stop the dose for a while or reduce the dosage and then recheck again. The other options that we have are you have to also decide when you want to do combination therapy. So, for example, if you have a patient who has extensive disease, extensive invasive pulmonary aspergillosis, where it's not just limited to the lung, but it's affecting other areas, and suppose they have, say, a recent hematopoietic stem cell transplant, or they're neutropenic from leukemia, or they have some kind of defect that puts them at risk for high risk of mortality, then you have the option of adding on an echinocandin to your voriconazole. So the echinocandin that was approved, if I'm not mistaken, for aspergillosis originally by FDA was caspofungin, but you have the option of either caspofungin, micafungin, enidulafungin, whatever you have in the hospital. Caspofungin usually is 70 mg load, and then I think after that 50 daily. And if it's mica, you would ideally like to use 150 mg daily. So you can use combination of therapy of azole and echinocandin in the cases of severe disease, but you'll have some experts that will go against it and say, no, I really doubt change in mortality. And they'll say cite some studies, but most of the mycosis studies I've seen have low numbers. And it's actually hard to draw concrete conclusions unless it's 100% obvious. The other drug of choice that's very important is liposomal amphotericin B. If it's limited to the lung and you have issues with voriconazole, suppose you're getting a lot of CNS side effects from voriconazole, or you have major LFT changes or drug-drug interactions and you want to use liposomal amphotericin B, it's appropriate. I would probably do 5 mg per kg if it's limited to the lung. If it goes to the CNS, then I would go higher of 10 mg per kg. You'd obviously have to monitor the kidney function and electrolytes very closely and maintain hydration. I tried to look up studies for the combination of liposomal ampho B and voriconazole, and they suggest that there is a possibility of antagonism when you combine these two. They say that the voriconazole accumulation in the cell wall would actually affect liposomal ampho B binding to the cell, so they don't recommend it. If you want a combination, I think they would say azole plus echinocandin. So these are the options that are very common. Now, you have other options also like posaconazole and isavuconazole. You can use these in patients where you want to minimize drug-drug interactions, especially in some of the cancer patients that are on a bunch of chemotherapy drugs. Isavuconazole actually has the least risk of interaction compared to the other azoles. It also has the benefit of QTC shortening, as opposed to the other drugs that are more QTC prolonging. And it also underwent a phase 3 non-inferiority trial for invasive pulmonary aspergillosis. I think this was more than 10 years ago, and that's how it got its approval. So it's a good drug. You would also check once you, it depends on the kind of formulation you carry in the hospital. If you have the sulfate form, you do the 372 mg every 8 hours for 6 doses, followed by 372 mg daily. And if you have the base form, you would use a 200 mg equivalent at the same frequency. The side effects, you can have a little bit of GI side effects. It's harder to check levels for this because not all labs do it. But ideally, if you send it to a lab that does it, it would be more than 1 mcg per ml is what you would target. And the other drug, posaconazole, ideally you would want to use either IV form if they're not able to take oral, or if they're able to take oral, you can do delayed release form. Delayed release form, you load them on day 1, and then from day 2 on, you just do once daily. Same thing, level after 4 to 7 days or 5 to 7 days, you'd aim for a level between, I think, 1 and 3.75. You go probably a little above 2 if you have pretty bad disease. You can get very occasional side effects from posaconazole. There's some case reports citing pseudo hyperaldosteronism, where you get high blood pressure, low potassium, etc., etc. But it's not very common. But these are the possible drug strategies. Now, immunomodulation wise, I'm sorry, do we have enough time, or I think I'll take another minute? I can't hear you, Dr. Batra. Sorry.
Can.
Oh. Immunomodulation wise, it would be ideal if you can reduce the immunosuppression on these patients, but it's not always easy because they have to also save their graft. If it's a graft, if it's a GVHD patient, etc. Well, GVHD, it's a different issue, but if it's a hematopoietic stem cell patient, there's some case reports that talk about, actually some data that talks about giving GCSF in some of the leukemia patients. It also talks about granulocyte infusions. There's probably a little more data for the GCSF infusions in these leukemia patients than there is for granulocyte infusions. And of course, debridement in surgery becomes very important in cases of rhinosinusitis. Occasional cases of pulmonary aspergillosis, especially if there's massive hemoptysis, or if the aspergilloma or invasive pulmonary aspergillosis is very close to major vessels or pericardium, and high risk of invasion and bleeding, or sometimes if it's a very large lesion and they have to undergo intensive chemo or hematopoietic stem cells soon, sometimes it is better to operate than just rely on medications because the medications may not do a good enough job. So these are the things that you have to look at.
I just summarize for the audience that azoles are the drug of choice, and as compared to head-on trials with amphotericin B, azoles, voriconazole is better because there are some aspergillus species like Tereus, which is resistant to amphotericin B. So voriconazole scores better over the amphotericin B, but we have to do reversal of immunosuppression. If there's any immunosuppressive factors, in neutropenia, we have to reverse that. At the same time, we have to make azoles. They have a problem with the therapeutic drug monitoring. That we have to monitor the drug levels. That is very important because side effects are also there, and sometimes we are giving it subtherapeutic doses. And once the patient gets stabilized, IV dose for first 2 days till the patient gets stabilized, that is 6 milligram per kg, and then change to 4 milligram per kg. Oral voriconazole can be tried, or itraconazole can be tried. And then there's something called salvage therapy, in which echinocandins can be given, and there's something called combination therapy, as discussed by Dr. Divya. And this combination therapy, still they are in trial. Some people, there's an advanced disease, we can combine voriconazole with echinocandins, and these are some of the salvage therapies. Okay, so I think since the paucity of time, we'll proceed. So my next question is to Dr. Swati. So when you suspect fungal pneumonia in the immunocompetent host, please unmute yourself and try to be a little concise.
To suspect a fungal pneumonia in an immunocompetent patient, we would not think of it upfront. We would actually, if a patient has been put on an empirical therapy and relevant investigations for viral bacterial investigations are sent, and there is no response, there is a non-resolving pneumonia, then we will surely think of a fungal etiology. Any patient who's having an antecedent severe influenza infection or a COVID-19 increases the risk, of course, and a good history should be taken in these patients because there are certain fungi which are endemic to particular areas. So a travel history is very important. Dimorphic fungi like blastomyces, histoplasmosis, and coccidioidomycosis are very prevalent in certain areas, and a travel history is important. And there are also, if the patient is having a smoking history, cannabis and tobacco leaves can have aspergillus and other molds with cryptococcus. So that also increases the risk of pneumonia in these patients. Exposure to bat and bird droppings can increase the risk of histoplasmosis and cryptococcus in these patients. So basically, there are many epidemiological factors, and of course, a non-resolving pneumonia will always put fungal pneumonia in our radius of suspicion.
Yeah, thank you, Dr. Swati. So my next question, we move on, and my next question is to Dr. Sushant. What are the risk factors and presentation of mucor infection in the patients?
Sir, mucor, if we can remember, after the second wave of COVID, there was a rampant rise in the number of mucor mycosis cases in lung. and it is the second most common after aspergillus to cause an invasive fungal lung disease. And risk factors, I would say, again, immunocompromised patients like hemato-oncologies and uncontrolled diabetes, transplant recipients, and long-term steroid therapy and other immunosuppressant drugs, trauma and burn cases. As far as the presentation goes, then I think number one, we will have to keep the rhino, orbito, and cerebral cases, and second would come solid organs like lungs, and then there would be on third or fourth on the list would be skin or kidneys, and then GI tract and disseminated forms. As far as the mortality is concerned, there it shows a very high mortality of more than some reports saying even 45% or up to in excess of that. And presentation on CT would, it can present as a consolidation or ground glass opacities, nodules. It could appear as a mass lesion or cavitations and mediastinal lymphadenopathy. Then pleural effusion may be seen, and it can show halo sign as well. So these are the CT findings, and due to a very poor drug penetration in the tissue, so surgical management would be the mainstay for treating such cases.
Thank you, Dr. Sushant. But one more factors are uncontrolled diabetes, diabetic ketoacidosis. That is very important because the acidemia leads to increased iron load, and that favors mucor infection. That is the mechanism of having more mucor infection in patient with diabetes. And so there are certain states, like iron overload states, patient on dexferoxamine, hemochromatosis. These are the patient also at a risk of getting mucor, and patients in ICU on broad spectrum antibiotics also are a risk factor for mucor infection. Thank you, Dr. Sushant. And now I come to Dr. Divya. So how do we diagnose and treat mucor infection?
Hi, Dr. Batra. So I'll actually keep it crisp. I realized I went over earlier. So clinical history. So for example, diabetes mellitus with ketoacidosis, like you said, risk factor. Other risk factors like uncontrolled malignancy, like leukemia, transplant, hematopoietic stem cell transplant or solid organ transplant or states of iron overload. So diagnosis wise, if you look at, apart from clinical history, when you look at imaging pathognomonic features are the presence of 10 or more nodules, the presence of a pleural effusion, large pleural effusion next to a possible mucor nodule, a halo sign or reverse halo sign, which is basically consolidation surrounded by ground glass from angioinvasion or vice versa, and sometimes concomitant sinus infections in the appropriate cohort. So these are the possibility for images. For actual, say, culture and pathology, on pathology, you'd see broad aseptate hyphae that are at a little over a right angle. These are the things you'd be looking for in the patient. Mucor PCRs, actually, based on the data I've read, are better than aspergillus PCRs. So if you actually look at the DNA load in mucor patients, the DNA load is sometimes 10 to 100 times higher in mucor patients than it is in aspergillus patients in terms of blood levels. So their PCRs are actually much more sensitive and specific compared to, well, specificity maybe not as much, but sensitive and very sensitive and specific compared to aspergillus PCR. So this is one important feature. And there are, the treatment is, you usually reach out for liposomal amphotericin B. If it's, maybe if it's only limited to the lungs, I do 5 mg per kg daily. And then if it's CNS, I would go up to 10. If I had to do step down therapy later, I would go down to either posaconazole or isavuconazole. But I would ensure that there's a period of overlap. And usually that period of overlap is about 1 week, where you can at least ensure that your azole levels are reaching therapeutic enough before you stop for your ampho B. And usually you would do probably 2 weeks of ampho B for if it's rhino disease. And if it's extending to cerebral, you would do longer number of weeks of IV, before you switch to azoles. And of course, surgery is very, very important, assuming that, it depends on the mortality risk, of course, but especially for rhinocerebral disease, it's extremely important.
Okay, so well said. We have in mucor, we have to look outside lungs also, because the rhinocerebral mucor canal involvement is there, and surgery is one of the very important points. Surgery has to be considered in mucor upfront, and followed by the the medications. So this is how we control the mucor. It's very aggressive infection, and people can succumb to death even within 48 hours. So that is why in mucor you have to be very proactive and do a diagnose. And one test I have discussed in my slide, that is called reverse halo sign. That is very, very characteristic for mucor, but can be seen in other infections also, like tuberculosis and all. So my next question is to Dr. Medhi. What are the risk factors for pneumocystis in immunocompetent host, and how you diagnose pneumocystis? Try to be a little short.
Yes. In immunocompetent host, the risk factors first I would like to say is an undiagnosed HIV patient. Suppose he was not diagnosed earlier, he is not on ART, doesn't know, and he comes up with the symptoms of dry cough, difficulty in breathing, hypoxemia, and you do a CT scan and you find that he has classical pictures, and then with a viral marker you see that he is a HIV positive. So that is one of the important factors for risk factors for PCP. And again, in other immunocompetent patients, we can see that patients who have structural lung disease like bronchiectasis, post-TB sequelae, or a patient of COPD or asthma who are getting repeated bouts of corticosteroid therapy for repeated exacerbation. So they keep getting steroids for a few days, few months like that, a few weeks. And then these are also patients who are at risk of having PCP pneumonia. And also elderly patients who are malnourished, or if they have uncontrolled diabetes, then again CLD or CKD type kind of patients. These are the patients who are on the surface immunocompetent, but then they have subtle amount of immunosuppression, and as a result they are at risk of having PCP pneumonia. And considering how to diagnose, first of all we look at the clinical features, symptoms of, like I said, dry cough, difficulty in breathing. And one thing we see that in PCP pneumonia, the patients, the amount of hypoxia is disproportionate to the amount of findings that we see in the CT scan. So that is one red flag. And then we have to look for the samples that we do, like a BAL sample or a sputum, induced sputum for fungal stain. And of course, we cannot do a culture because culture, it is not a PCP, cannot be detected in a culture. Then we have to look for the biomarkers like beta-D-glucan. And if suppose beta-D-glucan is negative, then we can almost rule out PCP. It is not PCP. If it is positive, yes, definitely there is a chance. And also we have to look for the PCR-based assays, which are very popular nowadays. So if you diagnose a PCP and DNA in the PCR, then we are almost certain that it is a PCP infection. Provided it is not colonization, we also have to look into other factors, like we have to combine the clinical radiological picture and the PCR and the biomarker, and combining all this, ultimately we will have to come to a conclusion of PCP pneumonia.
Yeah, very nice. So just 2 points I will add, that PCP pneumonia, even the X-ray can be normal in a patient with PCP pneumonia. That is what Dr. Medhi said. There will be clinical radiological dissociation. And one of the tests is blood test. You can do serum LDH. That can also suggest that there might be a PCP pneumonia. And as we have discussed, PCRs are very sensitive. Beta-1,3 glucan has sensitivity of 90% for detection of PCP pneumonia. And one patient who are on steroid and biologicals, nowadays a lot of biologicals are being used, they're also at risk of getting PCP pneumonia. So PCP pneumonia, you have to suspect who comes to you, who have an immunocompromised state and comes to you with hypoxia. So I think though X-ray may look normal, so CT scan or give you a diagnosis. And this PCR can be performed on because PCP patient do not have sputum also, so you have to do induced sputum. Induced sputum, non-invasive test, or nasopharyngeal aspirates, they can have a very good sensitivity on PCR. Okay, so coming to Dr. Swati, what is the treatment for pneumocystis?
Yeah, so in PCP pneumonia, the treatment of choice is trimethoprim sulfamethoxazole, and in the doses of either oral or intravenous, in the doses of 15 to 20 milligram per kg, in 3 to 4 divided doses, and for a period of 21 days. And if suppose there is a severe allergy, which is very rare, like a Stevens-Johnson syndrome or a TEN, then we can think of alternative therapy in the form of primaquine and clindamycin. Primaquine 30 milligrams daily, and clindamycin 600 milligram thrice a day for 3 weeks. Adjuvant corticosteroids need to be given in patients who have moderate to severe disease, like patients who are desaturating, have a PaO2 less than 70 millimeters of mercury. And in such patients, corticosteroid has to be gradually tapered over a period of 21 days, initially started with 40 milligrams BD. For 5 days, then 40 milligrams daily for again 5 days, day 6 to day 11, and then 20 milligrams daily till day 21.
Yeah. So thank you, Swati. I would like to also say that just now I got a message from Dr. Krishna sir. We have got near close to about 1,900 logins for the today's webinar. So thank you, CCI, for giving us this opportunity. So we are now we'll be going to last round of questions, and they'll be like basing on molecular diagnostic and neurodiagnostic test, and also newer antifungals. So my question is Dr. Sushant. How does the newer molecular test affect our clinical practice? Dr. Medhi, sorry. How does the newer molecular test influence or change our clinical practice?
Yeah, it has definitely helped us a lot.
Can you hear?
Hello?
Yeah, I can hear you. We can hear you.
So newer antifungal tests, that PCR diagnosis, etc., has been very helpful in giving us a early diagnosis so that we can start treatment early compared to the previous times where we used to wait for the culture to have a confirmatory diagnosis. But now, at least, if we have a positive PCR, we also have a positive galactomannan or a beta-D-glucan, and combined with a clinical diagnosis, then we can start treatment early compared to what we used to do while waiting for culture results. Secondly, to rule out that whether it is a colonization or actually an infection. So that also we have to see, because only with PCR we cannot come to a conclusion that it is a fungal infection. It may be a colonization. So with that, we also have to see a blood galactomannan or a bowel fluid galactomannan or beta-D-glucan. And if we find that both of them are positive, then at least we have a definitive criteria that, okay, this is a pulmonary fungal infection. Or if there is a colonization or infection of 2 or more sites, like it is in the lung plus it is in the urine, then we can go ahead. Secondly, previously we had to do invasive tests, like we need to do a biopsy, a lung biopsy or tissue biopsy for diagnosis and for culture. Also a BAL would be a little invasive, but now we can do a PCR with simple blood test, or with a induced sputum, which is much less invasive and non-invasive at all, to diagnose a fungal infection. So obviously it has helped us in our clinical practice, especially in ICU practice, to start antifungals early so that patients can get recovered early. Also, it has helped us to avoid the unnecessary use of antifungals, because we used to sometimes give empirical antifungal drugs or prophylactic antifungal drug. At least now, if we know that there is no fungal infection, the PCR is negative, then we can avoid unnecessary antifungal drugs and avoid increased mortality in patients.
Yeah, so that is what PCR has been diagnosis, but everything has got positive side and downside. So it may detect some in a non-clinicals, like we are doing in the testing for something and we get a fungal positive. So that is, we have to differentiate between colonization and infection. The other thing is clinical scenario has to be there. Like patient has to have some host factors, what we have discussed, environmental factors. Then only your probability of getting doing a test is high. The pre-test probability will be high. So then only we can accumulate all the data, like clinical, radiological, microbiological, all criteria we can include and come to a diagnosis. It's not only the PCR test can give us a diagnosis. There are many false positives, and then with the we have seen that the whole genome sequencing, nuclear, the next generation sequencing, they may also detect some fungi, which is all because they will detect the genome. So they may detect there may be some false positives also. So we have to see the clinical scenario also taken has to be in account before interpreting this test. Yeah. So well said, Dr. Medhi. So now I'll come to Dr. Divya again. How to interpret this neuromolecular assays and when to use this molecular assays.
Dr. Batra, I'll talk about the mucor PCR first. So, as I said before, because of the degree of angioinvasion of mucor, the DNA levels of mucor in the blood are usually much higher than, say, if someone had angioinvasive aspergillosis, 10 to 100 times higher based on a few studies. So, their blood PCR sensitivity is very high. It's higher than aspergillus, but it's still only sensitivity is around mid 80s. Specificity is around 95% for the blood. For BAL mucor PCR, sensitivity and specificity is extremely high. It's in the mid 90s. The other thing is people sometimes can use, physicians, persistent blood PCR positivity of mucor and think that the 6-month mortality or the risk of mortality in this patient, despite treatment, is probably still quite high. The fact that they have persistent PCR positivity. The second thing is some people use twice a week PCR, mucor blood PCR, as a preemptive strategy in certain cohorts of patients like leukemia and stem cell patients. That's for mucor PCR. Now, aspergillus PCR, again, you have blood and serum. I'm sorry, blood and BL. BL has obviously much higher sensitivity and specificity. Blood is only between high 50s to low 90s, depending on which study you do. The blood PCR is higher sensitivity in neutropenic patients, but that difference between neutropenic and non-neutropenic, you don't see in aspergillus PCR directly from the lung tissue. The other thing is, if you start them on anti-mole prophylaxis, like a lot of these leukemic patients, their PCR sensitivity comes down in the blood because their overall incidences are low and the overall sensitivity is also low. The other thing is when you start these patients, I presume the IPA patients on treatment, your PCR positivity can last a little long time. And it can also cause a little bit, in some patients, little bit of prolonged, what they would consider as false positive. And that's why it affects the specificity of the test. The good thing about aspergillus PCR is you can also check for mutations in CYP51A, those two common mutations. But really you need whole genome sequencing if you want to think of all the other mutations. There are some tests that do pan-fungal PCR where you check for mucor and aspergillus in the right cohort of patients like leukemia and transplant, where you want to be careful about your treatment strategy.
So I just wanted to ask you, where do you place this test in today's scenario? Like the patient comes, you will do upfront, or you will go with first non-invasive test and then wait for those tests to become, and then you will go with the PCRs?
I think it depends on the patient, Dr. Batra. Now, if it's someone who is, say, a high-risk patient, I would want to be a little more aggressive with testing upfront. Suppose I see a patient where my pretest probability is high, me adding this test will just strengthen the diagnosis that I've already assumed in my head. If I feel it's medium to intermediate and I see that the blood PCR for mucor is positive, it strengthens my argument. So it depends on the cohort of patient. I would not use it discriminately.
So it depends on the clinical scenario we are facing. If patient is very sick and all, an ICU patient, definitely we have to go with all guns, and we should not leave any test at all and do a very aggressive testing, because we know fungal pneumonias, by the time we get the conventional reports, culture and all, the patient may have succumbed to death. So that is what we have to be very liberal in doing tests in patients with immunocompromised and sick patients. So this is my last question to Dr. Sushant. What are the newer antifungals available, and any clinical advantage of these and upcoming antifungals? Dr. Sushant, you're not audible.
Okay. Yes, sir. Now, I would start with isavuconazole, which was introduced recently, and it has a long half-life, and it has It is the latest of the azoles, and once a day it gives the advantage of once a day dosing, and there is no QT prolongation, and has a bit better safety profile, and very effective in cases of invasive aspergillosis and mucormycosis. Now, the next generation echinocandins recently launched was risafungin, and it gives an advantage of once a week dosing. So there is a decreased hospital stay and better OPD care, and highly effective against Candida and Aspergillus species, which are resistant to the other azoles. And it has a fast upfront loading and rapid clearance of the fungi load, and offers minimum advantage of minimum resistance. Now, newer compounds that are coming up are olorofim, and it has a very high tissue penetration and very effective against invasive fungal infections like Aspergillus and other ones. Then there is Fosmano GPIX, which is a GLUT1 inhibitor, and it is specifically very much effective against the resistant strains of invasive mold and yeast infections, and also gives advantage of a better safety profile and higher oral bioavailability. And it can be used in resistant cases of invasive aspergillosis and candida and mucor infections. One more I would like to add here. One latest in the line is Ibrexa fungal, and it is cell wall synthesis inhibitor, and it inhibits the beta 1,3 beta D glucan synthesis, and it also confers high tissue concentration and effective against invasive fungal aspergillus infections and mucor infection. And then one more point of note here, the latest in line in is the opelconazole, which is the only antifungal that can be given in nebulization form. So this is you had already mentioned in your slides, and just keeping it short and important points.
Yeah, so we have got basically we have the two main antifungals as Rezafungin and then Ibrixa fungrep. That is the two antifungals which we are waiting at. They are in phase 3 trials because they are active against candidiasis, and they have half-life because there is a species called Candida auris, which is even resistant pan-azole resistance. And once it is a very also detected by nuclear genome sequencing, next generation sequencing. So that if we get these drugs, so we will be able to tackle these kind of infections, invasive candidiasis. So these are the drugs in pipeline, Rezafungin and Ibrixa grip for the invasive candidiasis or multi-resistant fungi. So we have done with our questions and the webinar for today, and we have got some few questions from the audience, our elite audience, respected audience. So there's one question from Dr. Vishal from Maharashtra, and I asked this question, Dr. Divya, already she has answered that. For diagnosed IPA, how frequently we use lifotyricin, amphotericin B and micafungin? So he means to ask how frequently we use combination therapy in patients with invasive pulmonary aspergillosis, or what is the evidence?
I think the evidence for like limited organ disease is low. It's much more for disseminated disease in patients that have very poor immune system to begin with. So if you take a host with a terrible immune system like stem cell, GVHD, multiple immunosuppressants, SOT, etc., or leukemia, and you take disease that is multiple organs, suppose CNS, sinuses, and lungs, then I'd be much more liberal with using combination therapy. If it's a single organ, I don't think I would.
So yeah, so if it is an advanced disease, so we can think of giving a combination therapy, but combination therapy is not as no, there's a not good concrete data on that. So it is obviously they said you have to give only single therapy, and when there's a stabilization, you change to orals, solid by IV. And I already discussed azoles have a much higher sensitivity against Aspergillus invasive as compared to amphotericin B. And definitely we can combine this therapy if the patient is not responding or there's some kind of azole resistance or there's a delayed response. So combination therapy can be tried. So it's not that it's not there, it's there in the data, it's there in the studies, but there is no concrete evidence has not come into guidelines. So right now the guidelines say only single therapy or sequential therapy and not a combination therapy. But we in the sick patient or sicker kind of patient or advanced disease, we can give combination therapy. It's justified. So is there any other questions? I don't see any questions. So anybody who wants to comment or your last final comments on today's topic of fungal pneumonia, one comment from everybody.
Dr.
So
Batra,
I'll start with Dr. Sushant first.
Oh, sorry.
As newer tests, and we can employ newer tests like PCRs, and depending on how serious the case is, we can employ these latest tests and take use of these newer modalities. And also new drugs are coming up, and they would just help in managing these difficult infections better.
Okay, so Dr. Medhi, your final comments?
Yes, so I would say that early diagnosis is the key. Before we had to wait for cultures in order to come to a confirmatory diagnosis, at least with PCR and new test, we can come to an early diagnosis so that we can avoid mortality in ICUs. Plus, we have to keep in mind that we need to differentiate between whether it is a colonization or a true infection. And apart from that, regarding treatment, we all have discussed. So new drugs are coming and which are better in terms of side effect profile, tolerability in patients. So we can use new drugs nowadays, especially posaconazole, isavuconazole. And compared to the previous drugs, since they have a better tolerability profile, I think it is better for the patient as well as doctors. It is more satisfying for us.
But isavuconazole comes at a higher cost also. The cost is very high. We have to consider that also.
We have to think of that also, but considering everything.
We have to take consideration. So well said, we have to take in the consideration. Okay, Dr. Swati, your final comments? You're on, you please unmute yourself.
So in selected group of patients, we have already discussed that if we suspect fungal pneumonias, then with the choice of proper tests, the proper samples, and the latest drugs that are being used in fungal pneumonia, we can surely come to an early diagnosis, and this shortfall or shortcomings can be overcome.
So this comes to conclusion of our webinar. I am Dr. Batra, moderator for today. I apologize, we could not cover every fungus in one webinar. So we have tried to cover our best and cover with aspergillosis spectrum, which we see commonly, mucor and pneumocystis. These are common fungal infections which we see not only in immunocompromised but also in immunocompetent host also. And we have tried to do our best to cover this webinar. And my final comments will be, any patient with fungal infection, take the history properly, consider the factors, consider every test with a pinch of salt, and take the clinical scenario, clinical context into picture before starting or initiating any drug. Definitely, you have to be very aggressive in immunocompromised patients, because these are the group of patients who will suddenly have a declining trend. So you have to be very aggressive in that, very liberal in doing testing, and starting an antifungal should not be misused just because the patient is in ICU not responding. You have to consider alternative causes, and the testing for all the funguses have got low sensitivity. So we have got a latest molecular assays which I have covered very extensively, that PCRs are a very good test, but for Aspergillus, for Candida, and Dr. Divya has said that this for mucorales, mucor also, the Aspergillus, the PCR is very, molecular are doing very good. They have a very good sensitivity, but also they have false positives also. So keeping these things in mind, I think we have concluded, come to a seminar. I would like to thank everybody for joining and giving your valuable inputs, and happy Navratri, happy Ugadi, and happy Gudi Padwa for everybody. And thank you and have a safe and good night.